Thank you so much. I have to say that when you say everybody runs away from physiology, wow, I mean, really, we shouldn't, because it is amazing, absolutely just gobsmackingly wonderful. And we're learning all the time more and more about how our bodies work. And as midwives, that's something that we should really be interested in, because we witness that unfolding, that physiological process unfolding on a daily basis, even working antenatally with pregnancy and in the birth room as well. It is quite wonderful. I'm going to just share the screen and bring up my presentation. Now, I know that, and I do hope that people attending this presentation will have seen the earlier presentation that I did, which actually we talked about that physiology in more depth. And I'm obviously carrying that conversation on, but I do want to just dip back again to remind us a little bit about what we're talking about. And do we know enough? That is really the question. We are not really trained that well in anatomy and physiology as far as birth concerned. And it actually, that gap in our knowledge really hinders us. But if we look at these pictures here, we've got a picture of the pelvis, the bony pelvis, wonderful. That's fantastic. Sacrum, two big hip bones, the ilium or iliac bone, and symphysis pubis at the front, which is joined together with cartilage, and the coccyx as well at the end of the sacrum. So we know that exists, and that's wonderful. And then we've got some dimensions as well, anatomic conjugate, obstetric conjugate, and we know those as well. And maybe that's some of what, maybe I remember wanting to run away from that because it seemed so complex, and I couldn't really translate that into the birth room for it to make sense to what was going on for these women and birthing people, especially when they struggled. So while that is valuable information, it is only a tiny part of what we need to know about. And then there's the pelvic floor itself. And of course, we do all know about the pelvic floor. That is something that's taught. And we understand that that's a very important area of our bodies, especially when we're having a baby. But we need to know more about that. And I just want to this is what we talked about in the first part one. So let's just look at it again and actually really take this in. Look at those photographs, those pictures. I just want to say, wow, every time I look at it, and I look at it quite often. It's amazing. You can see the whole body actually is connected. Everything's connected to each other, basically from the tip of our toes to the top of our head. It's all connected, and we have fascia, and we have muscles and ligaments running down through the pelvis onto the leg, the lower limbs, and upwards from the knees and the ankles, upwards through again, through the hooking onto the bony pelvis, across from the sacrum, across the pelvis through onto the top of the femur. That's the piriformis. We've got obturator internus that's attached to the pelvic floor, and we don't even talk about that. This is stuff we need to know about. And that's what I'm kind of feel like I'm on a bit of a mission, really. I mean, I started off with this really wanting to talk about helping people who were suffering from a labor dystocia. And indeed, that is the essence of what this is about. But if we don't know this stuff, this part of anatomy and physiology, then we really are hindered, because not knowing this translates into the birth room as a pretty huge gap in our knowledge, which means that we then practice, we have practices that hinder birth, and we don't even realize it for some of it. Let's have a look at this a little bit further. Here we have, I really want it to be very easily understood because it isn't that complex. And I think bringing it down to three main disruptions: a labor dystocia, three main disruptions of the physiological process that cause a labour dystocia are fear, medicalisation, and biomechanical issues. And I think we all recognise that, really. Fear, of course, is going to affect the neurohormonal exquisite orchestra of hormones. And medicalisation, as you can see in the picture, has a whole gamut of interference in the process. Many of those interventions, of course, are unnecessary. And we know this. We have studies and research that tell us that. And we know that because we witness it. And this is a birthing person on the bed, hooked up to all sorts of drugs, artificial oxytocin, most likely, and electronic monitoring and so on. We'll talk about that in a moment. And then this is the third one, which is what I'm really interested in, both the fear and I'm interested in all of it. But what can I do about it? I'm a hypnobirthing practitioner, so I can address the fear aspect, and I work with biomechanics and learn about it and teach it to the women, and that's my contribution to trying to make birth a little bit easier. The medicalisation needs all of us to start shouting out about that, and so this is how we can change that conversation, is by addressing these issues. So, as I said, I was going to talk a wee bit about the biomedical solutions, which we just see again, another picture there of a woman lying on her back, attached to all sorts of technology. And we do things to her so when she has a labour dystocia. These are often, this list that you can see is often what we are providing as a solution to that problem, but it doesn't address the root cause. Now, the root cause, and I'm talking specifically biomechanics, of course, because that's my thing. Biomechanics, meaning that the baby's, how does that baby pass through the pelvis? And it's most likely the cause is a imbalance in the pelvis, reducing the space available for the baby to pass through. And much of that can be resolved in other ways, which we're going to look at in a moment. But most of how it's addressed in the institution, in the hospital, is this list. Rupturing the membranes. We know that is one of the first courses of action that takes place. Let's break the waters and we'll see if we can get you moving forward with that. And that alone actually doesn't have a lot of evidence to support it. But it often goes along with artificial oxytocin augmentation. And even those two together are based on very low level evidence. I want to just say, I've written it down because I want to be really correct in how I'm quoting this from a piece of research. Zhang, Z-H-A-N-G. I haven't put it in the end of the, I'm sorry, I haven't included that at the end of the presentation, but if you look up Zhang, Z-H-A-N-G, and he did, and his researchers did a lot of work on that labour progression and partograms and so on, and actually put forward an alternative. As is quoted from their research, and it says, synthetic oxytocin has been classified as a potentially harmful medication and is in the list of high alert medication by the Institute for Safe Medication Practices in the USA. And despite this, the rate of oxytocin administration in Western countries has been reported to be between 44% to 75% in the last decade. That is quite astonishing, that we are using a drug that is a potentially harmful drug. And in fact, we have seen it ourselves. It has lots of contraindications. One of the contraindications is borderline CPD, cephalopelvic disproportion. And cephalopelvic disproportion is one of the reasons given for cesarean section that's been it's a labour dystocia, and the reason they've given it is CPD. and that goes down in the documentation. Now, CPD is actually really quite rare, absolute CPD, and that's because, you know, that's mostly to do with deformations of the bony pelvis, like rickets and so on, maybe even soft tissue tumours, or that's rare. It's a relative CPD is how the baby's passing through, and it probably is a bigger baby. Really, that remains to be seen if we're growing our babies too big for us to pass through our pelvises. I do have lots of doubt on that, and I think the evidence is very shaky on that as well. But much more likely, and in fact, this is what the studies are telling us, it's suboptimal position of the baby. So the baby's head is cocked to the side or deflexed, or the baby's OP. And those are the relative CPD issues. And here we are using oxytocin. It's contraindicated for that purpose. Are we causing more harm than good? Directed and Valsalva pushing. I'm sure that there's a lot of people who are listening to this who have witnessed that on a daily basis. It still happens in the birth room. Big breath in, chin on your chest, push, push until you're blue in the face, until your little hemorrhages come in your eyeballs. This is not a good practice, and it has evidence to say that's not good practice and it's not helpful. Electronic fetal monitoring is another one. It's an automatic if you have a labour dystocia. And I would ask you to have a look at Kirsten Small's blogs. She's an obstetrician in Australia who is really talking a lot about this and debunking a lot of the myths surrounding the benefits of EFM. There are very few. We need to be looking at that. Look at what we're doing to these women who are suffering a long labour dystocia, a long, difficult journey to have their baby. They're having vaginal examinations, not just a few, not one or two. They're having maybe even up into double figures. Because, you know, this is a long latent phase. This is then a very long journey through their first stage, perhaps, and their second stage. And vaginal examinations are not very reliable, and especially not reliable when you have a suboptimal position, because those landmarks are not there and we're not quite sure what we're feeling. And we also seem to rely very much on it as a predictor of how she's progressing. It's not a predictor, and we know it's not a predictor because we see women coming in and it's 3 centimetres and then 45 minutes later they have a baby. You know, so we know that can change at any time. I'm not saying it's not useful, because it has a place, of course, but we overuse them, and vaginal examinations are a really intrusive intervention. And 1 in 4 women have had sexual abuse in their lives, and that's the ones that we know about. So lying naked, half naked on a bed with your legs open with a stranger's fingers inside your vagina is quite something, and these women suffer terribly from those practices. Time limits, we don't, do we give enough time? Sometimes it's just an unfolding that just needs a little bit more, yeah, it just needs time to work itself out. And if she's not suffering too much, then that's good. She may find her own way to resolving the problem herself, as so many women will do if they are given the right environment. And of course, that's where continuity of care comes in, trusting your the birth professional who's attending to you and supporting you. And you know, being instinctive in your birth movements can help resolve a labour dystocia itself, but it's not, or it doesn't always work like that, but it does have an impact. Restricting eating and drinking, of course, that's nourishment, and it's we know that that is not evidence-based as well. And right now we're restricting birth companions, and as I said, having somebody you trust and know at the birth makes a huge difference to the outcomes. And in a labour dystocia in particular, that's a long haul, and it's a really long, difficult time not to have your birth companion with you, especially during these pandemic times. The language we're using is very detrimental. Failure to progress. You have failed. No, we haven't. Women haven't, birthing people have not failed. we have failed to understand. So we need to fill that gap in our knowledge and find out more so we can help them. In the environment, people who give birth at home and in birth units, centres, midwife-led units, we know the outcome is improved for them. And they, again, because that environment it is often, of course, a comfortable, safe place for the woman to give birth, but also for the birth practitioner who's in that environment is much more likely to have the philosophy that supports the physiological process because she believes in it and trusts in it. And of course, there's much more to it than that, but we've got, time is passing, we've got a short time to go through this. So what can we do? Freedom of movement, of course, is top. Freedom of movement, and that is quite challenging in an obstetric unit where you've got lots of machinery, but we can do that and we have to really, really look at that. However, what can we do if we've got a bed and we're on that bed with an epidural or attached to things? We have got a peanut ball, and we know that a peanut ball increases pelvic dimensions and it changes the shape of the pelvis depending on how you use it. And as you can see in this picture, there's different ways, and that's only a few. I mean, you can be quite creative, as I'll show you in a moment. And this reduces, we have evidence to support it. It reduces the cesarean section rate and it reduces the length in labour. Why don't we use it? If you're not using it, please do use it. And if you haven't got it in your unit, please get them. Really not an expensive tool to have. And here is a way of using it. And again, these are some biomechanical tool, but this is a way of using it which is really beneficial, especially in the second stage, in the pushing stage, where you want to open up the outlet. And instead of saying, open up your legs wide, and I think we talked about that on the last one, so do have a look at that. You have internal rotation of the femur, meaning you're pointing your toes to each other with your heels outwards. That opens up the outlet, and you can facilitate that with using a ball, and you can see that in the picture. There's a peanut ball there, and the midwife is illustrating that position. Her knee is lower than her foot, and her femur is rotating internally, and that's making more space for the baby. How are we doing for time? So we've got questions and answers, haven't we? I mean, a Q&A session after this, have we? Or
yeah. Just, so you've got till 12.
I've got not good. Okay. Just going to go back here just to say to mention this a little bit further. I thought I had less time than I did. Using hip opening, muscle releasing, fascial stretching techniques and positions will make a little bit more space for the baby. Remember, that's what we're talking about, a little bit more space. That's all the baby needs. This is what's stopping the baby calming down. This is the biomechanical issue. Now, it can be caused because, and it's got a variety of possibilities, because that biomechanical issue could be higher up in the pelvis, or it could be lower, or it could be all through the pelvis. So you might find that the baby is having a difficulty getting into the pelvis at the top properly, and you can do certain positions, or you can learn positions to encourage or suggest to the woman and birthing person to do that will help the baby engage better. And you can also use, as I say, this in the picture, this is for the outlet for the baby coming through past the spines in the midsection and out. There are things like Riboso, very simple things. Riboso, I'm going to show you one of the techniques in the next slide, but this is a Mexican scarf, and the midwives there use it as a tool. Of course, they've had hundreds of years using their Riboso, and they know it very well. If we don't use a Riboso, we're using just a scarf. It has to, you can't call it a Riboso unless it's coming from that country. But a scarf will suffice. And it is a really easy thing to do. And it's a very good thing to have to teach this partners, because then they can become a real support and help relax the woman, and also help the baby have a little bit more space. Sideline release is one of the positions I think is just amazing. It works really well. I'm just going to show you that in a second. But identifying early before the women become compromised, that is really important, and it's something that, again, we really need to work on. We are not very good at understanding or identifying a biomechanical issue in the labour room, in the birth room. We it does appear that we have struggle now to be able to identify or differentiate between the normal birth signs and the abnormal. Excruciating, agonizing pain is abnormal. There's something not quite right, and yet we have normalized that. And I know that those amongst you will have witnessed midwives who have said, you know, they've seen a woman come in and she looks like she's going to have a baby. She's really going for it. I mean, she's climbing the wall. She's going to have her baby. She's ready, and she's 2 centimeters. And they might say, if that's her now, what's she going to be like in active labor or true labor? And they haven't recognized that this is not correct. It is not correct to have agonizing pain when you're 2 centimeters. And we need to be thinking, well, what's causing this? Is it fear, or is it a biomechanical issue? And then, yeah. Oh, okay. Oh, you haven't. Okay. Thank you. So identifying early is really important. There's shaking the upper teeth. There's that rebozo. That is a rebozo that they're using around the buttocks, giving a good old shake. Those big gluteal muscles and fascia, piriformis, ligaments, everything's kind of good old jiggle, releasing tension. And you can put it around the thighs as well and jiggle that and really make a difference to how that woman's feeling. Now, you can use that all the way through the labour, just because it's a lovely thing to do. But if you actually run into problems if the woman's running into problems when she's pushing her baby out, then this is a really good way to release that tension, and the baby often comes after you've been doing this for 10, 15 minutes. Sideline releases in the other picture. This is really, really beneficial at any time in the labour if there's a labour dystocia. And it releases tension, it stretches ligaments and fascia and muscle in the hip, in the pelvis, and you do both sides. This one that you're seeing is a modified version of the sideline release. The sideline release would normally, the leg would hang freely, but in this position, it is modified for an epidural, because we're not absolutely certain if a full sideline release is if there's an issue with an epidural. We're not sure if that has, we don't want to cause harm. So we do a modified version, which works very well. This is a midwife in Chelsea and Westminster who uses this position very successfully, right up to somebody waiting to go to theatre because the baby's not coming out. So it's always good. We have these things that we can use, and I hope that we will start to use more gentle physiological solutions and come away from those harsh and harmful, many times harmful biomedical solutions. That's my website and links to the course. And of course, I teach professionals. I teach midwives and birth professionals this, because we all need to know about it. Okay. I think I've also got a few. That was from the last one, but it's still relevant, these references. Okay, thank you very much.
That's fabulous, Molly. Thank you so much. Now I'm loving the peanut ball.
Yes, totally. £10. £10. I know, £10 from Argos and other stores, of course.
Oh.
But I mean, it's not expensive, is it? And, you know, it can make a huge difference.
Yeah, and I think the apple tree, the shaking apple tree position, because that looks something that would be, I think I can imagine women would laugh if you were doing that.
Absolutely, Sue. It brings laughter into the room. It lightens everything up, and it just changes the atmosphere. And it's very enjoyable as well. As you're quite right. Yeah.
Yeah, that's grand. Well, we haven't had any questions through. If you have
Okay.
any questions, send them in, because we have 3 more minutes of Molly, if you choose to do so. I mean, I think it was interesting that some of the images of they really highlighted the sort of environmental ones of being very, this woman in the midst of all the
Yeah.
equipment. You can imagine being very afraid, and that really interfering with the natural
Absolutely.
oxytocins.
Absolutely. And there's a real overlap between fear and biomechanics. And when you have a biomechanical issue, and I've had one, my first baby was back to back. And so I do know from firsthand experience, but also witnessing and observing women and birthing people having their babies and having a biomechanical issue, there is a fear overlap because they know it's not working and they will say there's something not right. They've got this baby inside them. This baby is passing through their pelvis. They know, and they go, "No, this isn't right. Something's up," and they're fearful because it's sore. It's really painful, and really painful early on. It doesn't correlate with the progress in labour, and so there's a lot of fear. So you have to work out. That's our skill as midwives, to work out what is going on. I love that, and that's how I learned. I learned it from the women. A lot of my observations came from watchful waiting, watchful attendance. So,
and I think what you've pointed out is understanding the physiology, because if you don't, for example, understand when you've done a vaginal examination that the baby is OP, because I know, sometimes you see notes and it says unable to define position, and you kind of think, well, you should be able to have some idea somewhere. If you know that, you can plan ahead with the woman.
Yeah, and I actually think that if position undefined, that's already an indicator that it's a suboptimal position. However, of course, it's very complex, and we've only got a very short time to talk about this. Sometimes there's the 2 things I just want to finish saying with that is that it's not always a negative if it's what I'm saying is a suboptimal position, meaning that it might not feel OA, flexed OA. It might be a little bit perhaps asynclitic, because if it's higher up, it's actually the baby's trying to avoiding the sacral promontory, so it will naturally go into an asynclitic position to bypass that part of the pelvis, and then once it hits the pelvic floor, then it can sort its head out and rotate, and so that might be a natural progression through the pelvis that they may take that position up, and it might not be causing a lebertostosia. So we've got to match it with what else is going on. Is she struggling? It might even be the way she gives birth. She's individual. She might give birth like that. We see these women who come in and they get on with the labour and it's fine. And then the baby comes out and it's face to pubes. And we go, oh, who knew? Because it was normal for them. So that's not a lebertostosia, but if you felt that, you think, oh, that's not quite right. So it's quite, I love it, because this is what midwifery is about.
And I think I'm going to close at that point, because that is just a fantastic way to close your session.
Okay.
I think, thank you so much, Molly. I think your passion for this physiology, I think we all need a bit of that in our day-to-day life to understand and help women and their babies through the process. I think the individualization bit of it is so important. Absolutely. And that's absolutely fantastic. We're going to have to book you again, Molly, because it's just the story is not ended.
Absolutely. Thank you so much, Sue.
Thank you very much.